Well, we have a lot to talk about, so we're going to go ahead and get started. Many of you are aware that rural health is at a crisis point with over half of rural facilities operating at a financial loss and a third at risk of closure. And this crisis impacts the country, Utah, and those of us who have a vested interest in the health of the rural healthcare infrastructure. We have a tremendous panel for this closing plenary. I know I'll enjoy this conversation. These are individuals who are identifying solutions to this crisis and who are facing the complexities of this issue day to day. I'm so pleased to welcome Dr. Bill Beninati, Chief Medical Officer, Air Medical Transport, Telehealth Command Center and Outreach with Intermountain Health. I'll go in order. Casey Shakespeare, Executive Director, Rural Health Association of Utah. Brent Schmidt, President of Intermountain Health Sevier Valley Hospital in Richfield. Some of our panelists drove far to get here. We're so grateful for them. And then we have Dr. Brent James, Clinical Professor, Clinical Excellence Research Center, CERC, Department of Medicine, Stanford University School of Medicine. I'm Rebecca Nielsen. I'm a Managing Director with Health Management Associates. Thank you so much for joining us for this concluding panel. We're going to talk about a number of solutions today, and one that we'll drill down on is a telehealth-oriented solution. But first, we'll invite our panelists to share some of the most promising solutions that they see for addressing the rural health crisis. And Dr. James, could we start with you?
Certainly, and thank you, Rebecca. You know, I spent over 30 years at Intermountain Healthcare and got a deep immersion in rural health. As part of that experience, when I left Intermountain, they invited me to be a professor at Stanford. Stanford had a deep interest too in the CERC. Participated in a number of panels. We've been studying it for quite a length of time. The short version of my conclusion: the most important thing we should do is carefully explore telehealth for support of rural health services. I think we're going to hear a lot about hospitals today. On the other hand, we've been working on a paper and a conference where we don't look at hospitals, but we look across the entire span of healthcare, and it turns out there are some very, very attractive examples in every aspect of care delivery. Every element of primary care, maternal care, up and down the whole line. Specialist clinics, hospitals certainly play a critical role in the whole thing, up and down the whole line. And I have to say that I'm fairly sanguine. I've in a long, long time of working in rural healthcare, I think I'm more confident than I've ever been. So that would be the fun part to explore.
Thank you. Let's go down the line. Brent.
Yeah, I think just echo telehealth, and we'll talk a bit more about that, I think, during our time this afternoon. But the other thing I would add is this hub and spoke model with specialty care. How can we provide specialty care, that type of service that can't be done via telehealth, and still provide it? So we've been able to do that at our hospital with a hub and spoke model where we have some of these specialists, orthopedists, general surgeons, where they can cover some of the other rural hospitals and use us as sort of a hub and spoke. And that allows that specialty service where we may not be able to justify that surgeon just with our hospital alone. By combining several rural hospitals, we can justify that, have that service available in the community, and make them productive. And that's something that I think has been successful in our area and replicated in other areas, rural areas of the United States.
I don't know if I have anything to add to you two. I'd echo the same thing. Telehealth is huge. Being able to reduce that travel burden. One of the biggest burdens we see in rural is travel. And so if you can bring the services to the individual, it makes a huge difference.
Good. Well, that was a good setup. And if this is appropriate, I guess I could talk about sort of how our model works here. And it really comes down to keep care local. You know, and there's a couple of ways you can do that. One of the things that we do is a subscription model, right? So for many of the services that we give, particularly inpatient services, the local hospital pays a fee to us, and then we don't pay we don't bill the patients directly. Now we do have our outpatient services are done on a more traditional economic model, but I can step through sort of how that works. So for the patient, the benefit of Keep Care Local is obvious, right? Like, people heal better close to home, surrounded by their loved ones, and they are saved from the burden of having to travel extensively. And so what telehealth allows us to do is to give those patients access to a full panel of specialists without having to leave their home community. Some of those services, for example, tele-oncology, may involve them coming into the local hospital. And some of them can be done directly in their home. So that's how we see the patients benefiting. In terms of the rural providers, we certainly can help make life livable. It's hard to be a rural provider. You're on call in some cases 24/7, 365. And so some of our services like telehospitalist, telecritical care, we can take calls at night for them. We'll do a sign out, they'll go home. If there's something really big, they're gonna need to come in, but many times they can get a good night of sleep knowing that there's somebody who's very experienced that's working directly with the folks in the hospital to keep that up. And it also allows them to have the comfort of being able to practice at a higher level with that assurance that they know what the right thing is. The vast majority of my interactions, what I'm saying is like, listen, you've got it and you're doing the right thing, and I write that in the chart, and it's a powerful thing for them to be able to say when they're extending themselves a little bit that an expert from the big city has validated that that's the current best standard of care. So they can continue to grow and expand themselves professionally while at the same time taking care of the patients in their community. Step back a level, what does it mean for the community? Well, we know that in many of these rural, the hospital is the major employer in these communities. And if we can keep care local, right, we've kept the income for bed days, lab, imaging, pharmacy cost, all of that stays local. We can increase the case mix index so the hospitals can be compensated at a higher rate. And hospitals that are supported like that are not hospitals that are going to go out of business, right? We know that when rural hospitals close, there's a well-defined decrement in health outcomes for a substantial radius around that area. So if we can keep the income for the care local, then that hospital won't be at risk. And then finally, I guess, thinking about what do we get out of it? And, we're a mission-driven organization. So our mission is to help people live the healthiest lives possible. If we can do this, we're living our mission and we're living the vision of our system, which is to be a model. If there's something that we figured out, we want to share that model. I can tell you on the negative side, my team operates over 50 aircraft, right? And so when we're keeping care local, by the way, we're keeping those aircraft that we've already paid for on the ground, but that's okay. If that's the right thing to do, we're happy to do it. One other aspect which might not be obvious is, we're constrained by capacity all the time. And so if we can keep people in their community, that saves a little bit of capacity in our hospitals when someone comes along that needs what only we can do. Now maybe we've got that little bit of extra capacity that we wouldn't have if we were just, raking in patients around. So that's a summary of how our program plays out.
Dr. Beninati, thank you so much. You've painted this vision of the benefits that can accrue to rural providers, rural patients, and rural communities through this telehealth model where providers in an urban setting can consult with providers or patients in a rural context. Brent Schmidt, as a rural facility president, can you talk about what those benefits might look like on the ground, financial and non-financial?
Yeah, I think Dr. Bernardi did a great job of summarizing what that looks like. I want to just look at maybe 3 services, and we have over a dozen services, which is amazing. It feels like we're approving a new one every other month at our board meetings, which is great. But you mentioned tele-oncology, and obviously there's a financial benefit to rural hospitals with oncology, but I look at it more as the patient perspective and their ability to stay home, as was mentioned. And prior to us having tele-oncology, we had some really sad instances of rural patients either choosing not to go and get cancer care or they couldn't afford it, And so the ability to stay home has really been a game changer, or cases where they were coming home for their last treatment and got in terrible accidents. And so it's really significant in terms of the patient care that we're able to provide. The other one we look at, probably about 2 years old, is telepeds. And so as Intermountain looked at as a system, 60% roughly of the pediatric patients that we were transferring to primary children's were being discharged within 24 hours. And so you can imagine for the family that has to figure out work and childcare and transportation, only less than 24 hours to actually come back to where they were at, that's a lot. And so with the telepeds program, for those pediatric patients where it's appropriate, we're able to keep them close to home, monitored in an observation status with pediatric specialists at our fingertips. And they can be home and there's not the same impact, and we're really able to do a lot there. And then the last one that was mentioned is telehospitalist. And I can tell you, as was mentioned this morning, I think Rob talked about primary care physician shortage. It's very impactful in the rural communities. Primary care physicians are the backbone of a lot of these rural hospitals. They work in their clinic. They cover the ER. They're hospitalists. They are doing so many different things, and the burnout is real. And so it was interesting, the evolution. We brought the telehospitalist program to our medical staff meeting in 2019, pre-COVID. And the model was these primary care physicians are like, nope, we cover our own patients. Thank you very much. We're good. And came back about 3 years later, and the burnout was real. And they said, when can we start? Can we start tomorrow? And so, as was mentioned, these physicians who are used to being on call 24/7, 365, now can check out to an experienced provider and get some sleep, so they're ready to go the next day. And it's a form of retention. One of our physicians said, to me after we implemented it, he was within months of burning out and looking at doing something else completely outside of medicine. Another physician that we were actively working on recruiting said it was what made him decide to come to our community, because he wanted to have a long-term career, and he knew without that kind of break, he wasn't going to be able to do that. And so when you look at turnover, when you look at retention, those are very impactful financially as well for rural hospitals. And so that's another piece where telehealth can play a really impactful role.
Brent, thank you so much. We have two Brents on the panel, so we'll refer to Dr. James and Brent. Is that all right? Casey, do you mind talking to us a little bit about the value of a patient being able to stay local in receiving care? Any perspective on that?
Yeah, and Brent did a great job of describing the financial implications for that for the facility, so I'll kind of skip that part. But if you look from the patient's perspective, the reality of accessing care outside of your community in rural Utah, just a typical example of a rural Utah, and you're probably getting up at 5 a.m. to go out and do the chores before you can leave, feeding, watering all of your animals, driving 3, 4, 5 hours to get to Salt Lake. You're uncomfortable driving in Salt Lake. You're not used to traffic like that. Parking's a joke. We rural Utahns, we don't like to park very far away from the building we're going to. And it puts a lot of stress on them, and they drive all that way to be there for an hour or two, grab some lunch, and hit the road again and drive those 5 hours back and getting home just in time to do the evening chores and settle in. And just to make that day happen, you've got to coordinate with work. Think about economy in rural Utah. It's not nearly as many salaried positions with paid time off as what you see in urban Utah. So you're either burning one of your 2 days off for the week, or else you're losing revenue or income by taking an extra day off. They carry a lot of additional. We're busy people in rural Utah too. We like to do our farming, our ranching, our gardening, and so you're piling all those chores up on an initial day, or cutting yourself short one day that week to do all those chores. And if you have kids, you have to coordinate childcare. You're gone all day long. You might leave your spouse there, which means you're traveling by yourself to go to those appointments that you may or may not get news you don't want to get by yourself. And it's just a logistical nightmare. Then you add in things like the cost of travel, gas and food, and that's if you have a reliable vehicle that can make the trip. And if none of those things are issues, then you're facing weather conditions. It snows like 9 months out of the year in Utah, dealing with wildlife on the roads, road construction, our favorite pastime in Utah. and all of those additional barriers that make travel difficult. And like Brent said, I mean, accidents do happen in those trips. So when you add up all of these barriers and burdens that come with accessing care, what it usually results in is people just not getting care or waiting until they just can't wait anymore. One of my favorite jokes I see on LinkedIn, there's a guy that makes rural videos and talks about Farmer Joe coming into the ER, and the nurse comes to talk to the doctor and says, hey, he stopped building his fence to come in. And the doctor, he stopped. Did his wife bring him in? No, his wife didn't bring him in. Did he finish the fence? No. Get the crash cart. Right? Like they don't come in until it's that level of care. And so that creates more burden on the healthcare system as well. That's a lot higher acuity, maybe outside of the skill level or the resources for that rural community. And then when you do have people whose illnesses are progressing to that level, it adds a lot of additional burden on the healthcare system to care for that individual, and it may push them past their capacity in a rural setting. So there's a lot of different issues that come up, and solving all of these issues is extremely difficult, but if we can bring the care to them, it resolves most of them.
Thank you so much. And this was spoken by someone who made a 3 or 4 hour drive today. Thank you so much. All right. We're going to transition now. So we've seen a lot of data throughout the day. So Chartis, that does a lot of rural research for those of you close to rural healthcare issues, they put out a report about rural facilities at risk of closure, and Utah has comparatively few rural facilities at risk. And for those of you who've tracked this over time, that's been the case consistently. And so to what would you ascribe this relative success? Maybe let's go down the line again. Dr. Beninati, starting with you.
Okay, good. Well, one, I would say in Utah, 8 of the facilities are in our system, and so they're directly supported by the system. Now, not that they don't stand on their own, but we've got a lot of resources. One of the other things in Utah, we have an organization known as the Rural 9, which, we're outsiders to that organization, but we're proud to support that group of hospitals and admire, and we're fans of that group. And I think, in the prior session, we heard a lot about the spirit in Utah of cooperating and finding a Utah way to solve problems. I think the Rural 9, exemplifies that. And we do support some of those hospitals. A couple of them, we have full affiliation agreements. With 8 of them, we provide telehealth services, that have the benefits that we've described. But in the end, it's those hospital leaders on their own standing together and finding great solutions.
So the Rural 9, as many of you are aware, are 9 independent rural hospitals who collaborate in different ways. Casey, do you want to expound upon why Utah might be doing better relative to others?
I will say there's a few really powerful champions in Utah that really help support those programs. Matt McCall is one of those at the Utah Hospital Association. He's the director of the Rural 9, but we have a very well-ran SHIP and FLEX program out of the Office of Primary Care and Rural Health, and Ashley Moritz and Mark Watterson's team do a phenomenal job of supporting those facilities as well, and we do our best with RAW as well to help support those facilities. But I would say rural Utah has a real spirit of resilience and problem solving, and I would dare say we have some of the best rural hospital administrators in the country in rural Utah that really are expert at solving those problems and helping carry those burdens, sitting next to one of them. But I think it's that spirit and that dedication in rural Utah really makes a huge difference as well.
I think the collaboration is key. The Rural 9 meets, but we also get together as rural hospital administrators outside of that, because there's things we share in common, and we talk about solutions, we talk about best practice. We get together to discuss this, and we're not afraid to call each other. And then the telehealth services are something that's provided not just to Intermountain. As Dr. Beninati said, Gunnison Valley Hospital is 32 miles up the road from us, and they just started tele-oncology. And some may see that as a threat, but in my mind, I see that as if someone can stay in their community, even closer to their community, and receive that cancer care, then that's a win. And so I think we really want to make sure we're supporting each other, because these solutions can really continue to support these rural hospitals and make us even stronger. Because to your point, as I talk with my peers throughout the country, that is not the case. And these closures that are occurring are creating vast deserts for healthcare. And that, maternity wards are closing, some of these services that are really at risk, that really create, I think, really safety situations for patients in that community. And so I think we've been fortunate in our collaboration, and we want to continue to do that, and that's what's led to our success.
Thank you. Dr. James, any perspective you'd add?
It was 1986, that's a little while ago, when I, from a couple of decades being on the East Coast in academic medicine, moved back to Utah from Boston. It was stark. It was impressive, the difference. I would describe Utah as having a particularly communitarian spirit. You've just heard it 3 times. I think it's cultural. I think it goes back to the traditions from when Utah was initially settled. You play for the team, you take care of each other. That's what it comes down to. We've heard that. I want to change the pattern just a bit, Rebecca, if you'll allow me, though, with the mental model of how we cross-support each other a little bit. It's a way of thinking about what we've been hearing so far. The clearest example I've ever seen is the Mayo Clinic, believe it or not, talking with some of my colleagues at Mayo, a very fine health system. Let's imagine we were in an internal medicine clinic inside Mayo, structured in a very interesting way. It nearly always has a few very senior, very experienced, often specialist physicians. In the same clinic will be what I would call journeyman physicians, fairly advanced in their career, fairly strong, younger, just starting out physicians, but it extends even below that into what we would call sometimes physician extenders, advanced practice nurses, PAs, and even to people who support them. The thing that's fascinating when you watch that is how they work together as a team. It's surprising how much of the care is delivered down at the level of the extenders. I'm going to put a number on it. It's a guess, so not reliable, 70 or 80% done at that level. But the trouble is at that level of care, they'll fairly routinely encounter problems that go beyond their remit, beyond their training. They bump it up to the journeyman physicians. They'll encounter problems that they're bumping up to those senior leaders. That's actually built into their structure. Sometimes we call it top of license. And it's one of the main reasons that it works so well. It works extremely well. It's directly antithetical, by the way, to things like paying physicians on a relative value scale. Those measurement systems don't pick up the core of the work that gets done up and down a coordinated team. Well, imagine that we took that idea of a vertically structured team of concentrated knowledge coming up, but rather than doing what they call over the back fence consultation within physical proximity within that clinic, what if instead you stuck in a telehealth link? You see, but the same fundamental idea, but then link the thing top to bottom. I think that's what we've been hearing a bit, is one way of describing it. It goes a step beyond that too. Most people, when they thought telehealth during the pandemic, what they thought was a clinician on one end, a patient on the other. The first really good example I saw of a basically different model was Dr. Terry Box at the University of Utah. The U stole him from us, I'll say in passing, at the time. What it was in that telehealth link, instead of being clinician-patient, it was senior clinician, and at the other end of the link was a patient with a clinician. And it gave that specialist hands at a local level, hands, ears, eyes, contact, and follow-up at a local level. Those two ideas, I think, are the ideas that lay at the heart of the emerging telehealth models that we're starting to see. I just wanted you to have a model in your head of how you think about what you're seeing for a hospital. We have great examples of the same thing happening for primary care, from maternal care, maternity, across a whole range. I think in the little research paper we're writing up, I think we've got 7 of them, where this basic model takes place, and I think it's a game changer. And what we're seeing is some of the real successes of that kind of an approach, I think that's our future. You see what I mean? Take that communitarian spirit and back it up with a little technology.
Thank you for elevating those themes, Dr. Beninati.
Yeah, and I can just to extend that concept, and I'll say that I was born and raised in a very rural area. There was one non-farm business in the very rural town that I grew up in, but it was in New York. So to put a New York spin on what Dr. James said, when you know me, you know a guy who knows a guy, right? And so if I'm your telehealth doctor dealing with your critical care environment, I'm connected to a network of thrombosis specialists and infectious disease and neurologists and on and on. And one of the things that my team works very hard to do is to integrate all those resources to kind of team around the problem that that patient has, right? We can constitute a team that that patient needs quickly, and telehealth technology allows us to do that very fast with people that are spread. You know, one of the things, interestingly enough, our infectious disease program, our leader spoke about this at a number of national meetings, and now we've got doctors from Brown University, Johns Hopkins, the University of Michigan that are part of our program, right? They do their work at their local university, but a highlight of their week is the time they spend doing infectious disease treatment for us. And again, that's an example of that kind of network that we have. From somebody's home in Baltimore, they can connect to us and help solve these problems, and then that team goes away, but the next time we have a problem, there may be another team of specialists. And what we can do with telehealth is to keep the patient at the center, form a team around them, stand the team down, and keep moving.
Thank you. We have a last question that we're going to pose to all of our panelists, but I wonder if there are any stories that anyone on this stage would like to tell about patients or providers being impacted by some of the solutions we've been describing in a way that honors confidentiality. But if they're, Dr. Beninati, I can only imagine you have a bank of stories, and Brent, you've got a bank of stories, and Casey, you do too. And so invite any storytelling before we get to our last question.
I guess I'm closest to you. I can start. You're right. I've been doing this for a long time, so out of thousands of encounters, I got a lot of stories. But the first patient I cared for outside of Intermountain, and we have contracts with 45 rural hospitals around a 9-state region. And this was a rancher. I won't say what state he was in. He was a rancher that had pretty bad cellulitis and septic shock. This was a hospital that never had an intensive care unit. So that somebody who was requiring fluid resuscitation and vasopressor support would have been shipped out. And instead, he was kept local, and we supported the local team. And that morning, I turned on the camera to check on him, and the nurses had succeeded. He'd stabilized, and they'd stopped the norepinephrine infusion. And I camera in to say good morning to him, and he's out of bed getting dressed in his clothes, right? And because he had to go feed livestock. Now, normally, you turning off the norepinephrine, you would stay in the ICU for a little while, watch for stability, go to the hospital floor. But in his mind, he was a tough rural guy. In critical care, he'd been there, done that. The norepinephrine's gone. I got livestock to feed. Sorry, doc. And I just love that we were able to, that was even a choice, because until that happened, he would have been in a big city and he would have been fretting and worrying about who's taking care of his livestock. So we gave him that choice. Now, we got someone else to help him for that morning, but that night he was home taking care of his livestock. So
I have one for you, Rebecca. It's a little while ago. It was a 15-year-old young man. I don't know how it happened. He got hit in the head with a golf ball that was traveling at a pretty good speed. Pretty bad traumatic brain injury. His only local health care within about a 2-hour drive was an advanced practice nurse. That advanced practice nurse, I guess we could call it tele-ED, was tightly connected into a larger system. Enabled the advanced practice nurse to very quickly stabilize the patient, very quickly diagnose and understand the problems. At that level, they had pretty good imaging, believe it or not. With some of the imaging equipment we have today, you can actually implement that at a level that a properly trained technician or an advanced practice nurse can support. This one did involve a helicopter, but it very clearly saved a life, if you see the idea. Stories like that are almost endless. The problem is that I don't think we've done a good enough job as a system in taking those sorts of technologies and deploying them broadly. Now, the other thing we haven't discussed is how do we pay for the services? How do we keep them alive? That'd be a conversation for another day. But I think our capability to deploy state-of-the-art care on a very broad basis, backed up appropriately by transport, it just continues to advance. It's already so far beyond what it was even a decade ago and continues to climb.
I shared the story about the physician, the provider, and the burnout and what the telehospitalist program meant to him, and so on into that. But, it's at typical small towns, everyone knows everyone. And my father-in-law was one of the, not first, but in that first couple of years to receive tele-oncology care for pancreatic cancer. And, unfortunately, he passed several years ago, but the ability for him to stay close to home, to not have to drive home for 2.5 hours feeling really sick after a chemo treatment was really, really meaningful. It was meaningful to our family. It was meaningful to him. And so that was personal to our family. And a lot of rural stories are very personal. These are our friends. These are our neighbors. These are people we see everywhere. And so to be able to have that technology impact us personally was really impactful in terms of allowing us to have more time with him, to have him home, to have him be closer to family, and not have to be on the road all the time for these types of treatments. It's very significant to the loved ones of these individuals that are going through these really tough situations.
During COVID, I actually was working in Carbon and Emery County under the HRSA Rural Community Opioid Response Program. And I worked in that program for over 6 years and had been working in it for a couple of years before COVID. And when COVID rolled around and Medicaid expanded what types of visits could be covered by telehealth, there was actually several individuals that were being treated by partners that we were working with in that community who did better with substance use recovery during those years than they'd ever done before because it took the transportation barrier out. They weren't able to get in regularly, and they were able to get their care at home instead, and that made a tremendous difference.
Thank you so much. All right, we're to the last question. And we're going to invite everyone on the panel to answer. How can our audience members support the cause of rural sustainability? Appreciating that we have individuals in the room with all different backgrounds, so kind of pick your audience member of choice. But Dr. James, can we start with you and then we'll work down the line?
This is a really tough question. I'm not quite sure who's in the room. But here's how I would probably summarize it. If a group of people of this level of expertise and this breadth of experience were to come to a common shared vision of what could be, at least within a reasonable limit, and then share that voice broadly, I think that this is a societal level solution, almost a state level solution, as opposed to individual organization level solution. I think this is going to take some shared work along the way. How could we come to a shared vision of what could be, and then over a number of years start to build toward that vision? Would be the main idea. It would give people a chance within a framework then to create and to innovate and to share. And I think together we could go much, much further than we can go alone. So.
Now I think back to just the group we had up here before, and programs like 340B, critical access status, are very significant to rural hospitals. and they're significant to sustainability. And so I appreciate Francis Gibson, I appreciate our representatives, our legislators, our senators, in really keeping in mind, I understand a large part of the population lives, in these big suburbs, but we do have people in rural areas, and I appreciate them keeping them in mind and understanding that really these types of programs are, as Francis said, it may be a blip on a trauma hospital, 1.5 million, but to a rural hospital for a 340B program, it's significant. And so really appreciate their support. So continue to encourage your representative to support rural programs like this. I think is going to be critical to the ongoing success.
I would say understand and appreciate that urban solutions don't always work in rural. The delivery care model is different. The auxiliary resources are usually much more sparse. And if you come into rural and try to apply your urban solutions, a lot of times it's going to fall flat. But don't leave rural Utah out of the decision-making process to decide how to proceed. Rural Utah is full of many very intelligent and innovative individuals who would be happy to be a part of those conversations. And in order to get buy-in from rural Utah, you have to include rural Utah, and you have to appreciate and show respect for their culture, because the culture is different. If you've never lived in one of those little communities with 1,500 people, 500 people, you just don't understand how different it really is living in an environment like that. How well do you really know your neighbors here in the Wasatch Front? I knew what everybody's cars were, what they drove, what their dog's name was. We knew if they were gone on vacation. It's a much more tight-knit environment. And it's hard to appreciate how different rural really is, especially rural Utah, which is different than any other part of the country. I think with rural, then it's difficult to understand sometimes why those solutions that work in the Wasatch Front don't work in rural. And so you have to keep that in mind.
Boy, it's going to be hard for me to say anything that hasn't already been said, so I guess I'll just underline it. I mean, there's an incredible sense of community out there, and there's an incredible sense of innovation, and look for opportunities to be part of that, right? Have your eyes open and your ears open, listen and see what the problems are, and find ways that you can cooperate in the solution, and I think we'll all be better off.
Thank you so much. I was so heartened that earlier in the panel, Dr. James mentioned that he had this feeling of equanimity about the future of rural care, and we've heard some hopeful things despite the headwinds. On behalf of the State of Reform Conference, thank you so much for joining us today.